a pleasure to introduce Jodie Buckingham, someone else with a connection from the northeast, I'm delighted to say, from Sunderland originally, which is why I did a little bit of orthopaedics when I was a medical student, which is possibly why I didn't do orthopaedics, I'm not sure. But we won't go into other reasons, we've got too many surgeons here. But and she's graduated from Durham in the northeast and has been working in Oxford now for several years. And she's really the lead podiatrist there, and she's going to talk to us about the expanding role of the podiatrist in the UK. So very welcome to Malvern.
Thank you very much. I said to a few of you before I came to talk that I was going to brave it and not bring up any crib notes, and I'm very glad that I did, because you would think that me and Nikki had planned it and maybe spoken before or met before, but I am going to shift around my talk as we go, because Nikki's model that she talked about in the northeast is very similar to the model in Oxford, and I'm going to try and expand slightly then on the bits that you didn't touch on around inpatient podiatry and how you're moving things forward, rather than cover something that we've covered quite recently. So it's lovely to be out and in front of actual people is the first thing to say, and the second thing to say is I was a little bit stuck about what I was going to talk about. It's a big topic, and I initially started thinking about what is in my day job and what's in the day job of my team of podiatrists, and I thought, the core thing that we do is deal with feet, isn't it? We're there treating feet, we're there debriding, offloading, hands-on, but we do a lot more than that. Lots of education, lots of kind of service development, dealing with commissioners, thinking about data, bits of leadership, all sorts. And the thought of covering that, and there might be more on there actually, there is. The thought of covering that in about 15 minutes was a little bit daunting. So what I thought we would do is go through some areas where we've been working in Oxford over the past few years, and hopefully pull together some themes that run through all of those that we can all learn from. And if we have time, think a little bit about the future too. So, like I said, Nikki covered her pathway very well. The pathway in Oxfordshire is unbelievably similar. We have an integrated pathway for all patients with diabetes. The low-risk stuff out in primary care, the at-risk, high-risk stuff in community, and alongside that, the community team do quite a large amount of wound care too. So that should be the less complicated of the diabetic foot wounds. Not always the case, if I'm honest. Some of it's down to patient choice and the likes of, so sometimes they do end up seeing the more complex feet too. Like Nikki described, we have community diabetes leads, and they sound very similar to what's in the northeast. They, in the purest sense, spend a day a week in the acute foot clinic and the rest of their time out in community, and that is an absolute godsend. You've just got a link for patients, a link of knowledge, a link of skills that I just don't think you can replicate without that kind of setup. And then we have the acute side of things, so the complex wounds, the surgical cases, the foot emergencies that sit within the hospitals. Very similar to what Nikki said, we're a large hospital, we're split across 4 sites. The specialities are split across those sites, and it's a bit of a nightmare. So I'm going to go straight to inpatient podiatry. Back in 2013, there was one whole-time equivalent for about 1,000 beds across those 4 sites. At that point, that felt quite luxurious, if I'm being honest. There weren't many inpatient podiatry jobs about. I went for it, and I loved it. But it wasn't enough. And if you look at the national data that comes out from Nadia, we were in a similar position to the majority of the rest of the country. So what were we going to do about it? First of all, we decided we needed to do an audit. So we would look at the care that people were getting. We've got a little bit of wind. Anyway, we'll be all right. So we would look at the care that people with diabetes who were in hospital got with regards to their feet. I'm sure many of you will remember the nice NG 119, which was a big hefty document that set out some standards with regards inpatient care of people with foot disease. In summary of that very lengthy document, it was looking at do we look at patients' feet when they come into hospital? Do we know who has a foot ulcer or a foot problem? And do we make sure those that have a problem get the right care in the right time? So we went and decided, alongside the kind of standard Nadia, that we would, as a podiatry team, go and take the shoes and socks off every patient in the hospital on that day that had diabetes and see what we found, and look to see who had a problem. And when we found a problem, look to see if we knew them and what their standard of care was. The summary of what we found was that there were lots of ulcers that we didn't know about. Frankly, not everybody was having their feet looked at when they came through the front door. So who knew if we were causing harm and giving those patients ulcers, or if they'd had them for 5 years? Bit of a mystery. We found... I guess it makes sense, obviously, because people weren't looking to see if there was a foot problem. It wasn't being documented. So the prevalence of inpatient foot disease was much higher than the national data suggested. Within our own data, so comparing when we'd gone to look at feet to what we reported in Nadia, there was about 100% increase of foot wounds. Not all of those patients were in because of their foot disease, but they happened to have foot disease throughout that admission and needed some care so things didn't get worse. The figures were grim, which definitely helped in some ways, but we basically found over a number of years our compliance with the key guidance for inpatient management of diabetic foot disease, we were sitting between 0 and 5% compliant. So we needed to do something about that. First of all, we established an inpatient podiatry team. This is us many years ago. And we were able to see lots more patients. We were able to do a lot of work around making sure patients were discharged sensibly. We really integrated with the vascular team too, so we do a vascular ward round twice a week, and that's been kind of a core standard for us from the word go. But we, I guess, quite quickly realised that we were, with a kind of finite team of us, we were just basically scratching at the surface, and we couldn't go and find everybody that had a foot wound. We needed to rely on other people. So we came up with a bit of a plan. Our first kind of strategy was staff education, and we went broad. Oxford University Hospitals is a big trust. It employs about 11,000 people. Oxford, if any of you know it, is an expensive place to live. The turnover of staff is high. So you have about a 10% churn of your staffing constantly, which is quite significantly higher than the national average. So we linked into some established networks with the tissue viability nurses and their link nurse system, the diabetes specialist nurses and their link nurse system, and basically shoehorned feet in wherever we could. Because whether we like it or not, to people outside of this room, feet aren't that attractive or often that interesting. So we just had to make sure we had a little theme of feet running through every kind of avenue that we could. We went a little bit rogue with some of our teaching. So we made sure that we were involved in all junior medical training that happened within the trust. So your F1s, your F2s, CMTs, everything like that. We got in there somehow. And again, your F2s in the middle of the day that are sitting trying to eat their lunch and, you know, have only really come to the training so that they get their sandwich, aren't necessarily that interested in hearing about feet. So you can see on the screen, one of the kind of ideas we had was to use the Sinbad wound classification as a teaching tool and an aid memoir for them. And And we went sailor themed. So Sinbad was a sailor, and we went all out on a nautical themed training package for them. It lasted about 10 minutes. Arguably, it was the target audience was about an 8-year-old boy, but people either loved it or hated it, but they remembered it. So the next time they had a grotty foot in front of them, they would definitely remember that there was some slightly odd podiatrist standing in front of them a few weeks ago saying something about a boat, which would trigger a memory to then go and look at the site where we directed them to. And we kind of promoted it as something that would help them. So when you're standing there, not knowing to do with that foot that's got pus squidging out of it, if you go through Sinbad and think about every bit of it and put in place what we've suggested and then shout for us, your patient will be safe and you will get a happy podiatrist when they come to review your patient. So we went with that kind of theme, and we our next kind of thing that we thought we needed to do was shout about when things went wrong. So very similar to what the last two speakers have said. Don't just shout about what goes well. Talk about what doesn't go well too and learn from it. So we were the people that were shouting, saying, oh, we've caused this person to have a category 3 pressure ulcer to the heel, which doesn't necessarily make you popular. But if you are there to support the team with the investigation that happens, and you're there to help them make things better and learn from it, then it suddenly becomes a lot less threatening. So we've done a lot of work with that early days. And then we done lots of, as a team, we didn't do the quality improvement projects, but we were there to support them. So through doing the first two things, we raised the profile of foot disease within the inpatient setting, and got people a little bit interested. We said at the end of all of our teaching sessions, wherever you're working in the hospital, if you want to come and do some work with us, if you want to make things better for your patients, we are here. And we had quite a good response to that. All of our F2s in the trust are expected to do some quality improvement work and present that back at a kind of internal conference every year. So we had people jumping at the chance to come and do these things. We decided not to give them the solution, and we decided to ask them to come up with the solution in their local area where they were working. And we were there to kind of be the thread that kept it going longer than their 6-month rotation in the trust. And ultimately, the reason I've got the touch of the toes test up there is, surprisingly, they found through their QIP cycles, that the barrier for, or a solution to for screening on admission was to implement the Ipswich touch test, but based on the work that Jerry had done up in Ipswich. So, what was the outcome of all of that within the inpatient setting? By 2020, we have 80% of patients with diabetes having foot checks within 24 hours of admission. Truthfully, most of them have them within 6 hours, but we measure on 24. That is sustained. So we're on about our 5th audit cycle that hits about 79 to 81%. So it does feel like there has been a change in practice, a change in process, and it is embedded. I am mildly nervous that we're going to audit it soon after COVID. I'm not sure what impact that's going to have, to be honest. But we got there once, so if we need to do it again, we can do. Because of that work, we were then actually aware of every foot wound. So when we went to do that trawl around the hospital one day a year, take everybody's shoes and socks off, there were no surprises. And the thing that I didn't say earlier was, if the right people knew about the patient with foot disease, they got the right care. So the fact that we knew about every foot wound meant that the patients were being well looked after. And I think something else to say from an inpatient podiatrist point of view is we're in a really lucky position that we have quite a strong voice. So we are now seen as the people who are able to manage diabetic foot disease in an inpatient setting for whatever reason that patient is in. And we have quite a strong voice on your medical ward round and on your surgical ward round. And that's quite a big shift from a professional point of view. And I think Nikki had said you now get the vascular team come in to ask for the podiatrist because they're learning from them. We're in a very similar position, which from a professional point of view is quite satisfying. So I'm going to speed on and talk quickly about the multidisciplinary foot team. Pre-2017, we had a multidisciplinary foot team, but it lacked a bit of structure. It was spread across 4 sites. It was variable depending on how you hit the service, and there were delays in non-urgent care. NHS England funding, we set up a weekly clinic, we've got a daily remote review if needed, and we have a governance arm. It involves all of the normal people. If there are any microbiologists in the room, you guys were a game changer to us. I'm more than happy to talk about that over coffee later. It's the best thing we have done, bringing the microbiologists into clinic. What difference has it made to patients, and what have we done? So we managed to run a full clinic pretty much every week. We see about 15 patients in 2 hours, face-to-face. It's rapid. We see people quickly, so the wait for people has significantly reduced. The appointment burden for these patients has reduced also, so they will have lots of appointments for lots of different problems, and we're pretty much halved the amount of appointments they need to come to, which has got a cost saving to it. The financial figures are very rough, but they are there. We have managed to stop as many admissions, and those people that are admitted stay for less time. Again, very rough figures, and we're working with a healthcare economist about it to make them a bit more real. But your commissioners can't really argue against this data. It's strong, and it will help you get services funded. And the most important thing is we've stopped chopping off as many limbs. So the blue line is major amputations and the trend line is coming down. You can see that a bit more easily here. Yeah, we've basically switched from doing a huge amount of major amputations to more minor amputations. The last thing to say is COVID's had a huge impact. We've continued services. We have made sure the vulnerable patients were looked after. We've relied a lot on voluntary organisations to come in and help them with things outside of their feet. There was rightly so a huge reduction in preventative care, and that has led to harm to patients. We have patients turn up with significant foot disease, and the first time anybody meets them is when they're admitted to hospital, and that is really sad. But what I would say to the podiatrists in the room, you need to collect that data. Definitely collect that data, because we have struggled as a profession to show our worth in preventative care, and this is the time that we can prove it. So there's a little bit of a call to arms for that, and say, don't worry about your professional boundaries, use the right skills at the right time, collect your data, understand it, and I think the key thing is podiatry can thread that all together. So you're the link between the different aspects of the service. And that's probably it from me, a bit of a whistle-stop tour through a lot of work that we've done, but hopefully we can have some conversations outside of here that will be useful.
Yep.